Good morning. You're listening to Masterclasses in Dermatology Saturday Morning Live. I'm Joe Merola.
And I'm Alice Gottlieb. Great to have you with us.
This is your weekend clinical reset. We're fast, we're focused, we're built for real life, real clinic life.
And we'll keep it efficient, practical, and a great way to start your morning.
Each of these sessions is designed to give you something that you can take straight into practice.
And we also want to thank our platinum supporters, Eli Lilly and Company and Regeneron Pharmaceuticals Incorporated, for making this program possible.
So wherever you're joining from, we're glad you're here.
Welcome to Masterclasses in Dermatology Saturday Morning Live.
Hi, I'm Joe Merola, a dermatologist and rheumatologist from UT Southwestern Medical Center in Dallas, Texas, and I am joined by someone you all know very well, my co-director in this wonderful program, Saturday Morning Live, who instead of being in the interviewer seat is sitting in the hot seat. Dr. Alice Gottlieb, friend and colleague, who is also a dermatologist and rheumatologist at UT Southwestern Medical Center. What are the chances, Alice?
I'm privileged to have the best boss in the world.
I appreciate that. Well, I know you all are in for a real treat with this session because Alice is, as you all know, a guru of HS as well as psoriatic disease and many other areas. And we're really taking a deep dive this morning into HS. And so, Alice, because there's so much to cover, I'm going to jump right in. And these are a couple of really big questions. So we'll try to dialogue as much as possible, but I think we want to learn from you as well. The first big question I have for you is, and this is a big one, but what are our unmet needs currently in HS treatments? There's a lot of new stuff flying at us. There's a lot of older therapies. Where are we? What's the unmet need, and what's sort of flying our way?
So I'll take a helicopter view and then we can go into more detail. First of all, we need more effective treatments that are also safe because we seem to have hit a sort of a plateau. I do think we need to manage the comorbidities better. The comorbidities are at least as bad as that for psoriatic disease. I think here we have unmet needs in education. Since dermatologists are not the only people that HS patients interface with, it's primary care, HCPs, and by that I mean doctors, PAs, NPs, ER. They often show up in the emergency room. Dermatologists need better education, OBGYN, and our plastic surgeons, because it's not always dermatologists who are doing the surgical repairs. We need to educate patients better. Many patients really don't know about their disease, and some of them are treated poorly. I mean, they're made to feel dirty. They're made to feel ashamed that they smoke or that they have more weight on than maybe you would want to have. So patients need to be educated that they are still beautiful, that they are still important human beings, and there's hope. Finally, not finally, penultimately, probably, we need earlier treatments to prevent scarring, etc. But also, there's evidence many times over that the longer you have the disease, let's say 10 years being the cutoff, the worse the outcomes is when you finally do start to treat it. Early treatment is better. And I feel very strongly about this, and at this age where I think advocacy is needed. Many of my patients don't have access to these wonderful treatments. They don't have access to the weight loss drugs, and many of them don't have the kind of insurances that give them access to good treatments, and for that matter, even perfect doctors. So access is a
That's
huge
great.
issue. And that's my summary of the
That's
unmet.
great. No, and it's a wonderful summary, and I think it just underscores how much we still have to go in the HS arena. So I think we're going to start to unpack that one by one because I have questions for you about comorbidities. I have questions about, therapeutics. Maybe we'll start with the positive hot topics, which is not to turn it on its head because we could talk about current treatment, current therapy and algorithms, but let's be forward looking and let's be positive. What's emerging in this space? What do we have right now that are sort of new classes, and what's emerging that you're excited about? Because everyone wants to hear where we're going to bridge the gap in the coming years.
So the first one I want to talk about are the nanobodies. Nanobodies are partial antibodies that are smaller in molecular weight and I guess theoretically thought to penetrate into deep lesions better. And we have two that I'm going to highlight today. One of them is sonelokimab, which is an IL-17A and F nanobody. And the results are looking very nice. They've raised the bar, and there's one study where they show that a high score of 75, not just 50, that there's a 17.5% placebo and 34% reach the high score of 75 at week 16. Now we have another nanobody, but it's a totally different and new target. It's one that targets both TNF and OX40 ligand. And so it's also low molecular weight. And by doing so, it's felt to target not only T cells, but antigen presenting cells and also B cells. That's one of the surprises. I mean, whoever thought of B cells 5 years ago? Only smart people did. I mean, and here they have a phase 2 study that shows that their high score 75 at week 16 was 54% getting the drug and 22% with the placebo. However, I do think that we have to wait and see what's going on further because you did see candidiasis, you did see increased liver tests, function tests, and genetic variants in the OX40 ligands pathway and OX40 ligand system have been reported to get Kaposi sarcoma. And so I do think that we have to watch this out. And I believe that one of the problems with the atopic dermatitis study that also target this pathway is there were some Kaposi sarcoma. So we do have to look at the safety in bigger studies in phase 2. But it's still very exciting because these numbers are very nice. Speaking of B cells, there's remibrutinib, which is a pill, and it's already approved for chronic urticaria. We're going to get urticaria back to dermatology, and but now we're focused on HS. And who knew? They're looking at phase 2 study, high score 50 at week 16, and let's take the 25 milligram dose. 75% of patients achieved that high score 50 with a placebo of 34.7. There was some increased bruising, but that was an expected side effect due to the mechanism of the drug. Not worried, but you already have the same drug is already on the market. So I think that's exciting. We also have two JAK inhibitors who are old friends, but who were being applied to HS. One of them is povorcitinib, and the other one is upadacitinib. And both povorcitinib has phase 3 studies looking at high score 50 at week 12, and roughly around 40% of patients achieve that high score 50 at week 12 versus 30% in the placebo. For upadacitinib, the numbers look kind of similar, but they haven't had a historical placebo. So I'm just going to the historical placebo was 25%, and those who got the real drug, it was around 40%, 38% achieved that. Finally, we have a whole new class of targets that people weren't thinking about except the very smart ones. One of them is lutikizumab, which is a dual IL-1 alpha and IL-1 beta monoclonal antibody. And most recently, like a week ago, we had a report of abdacabart. I'm not sure I'm pronouncing it properly, but phase 2 study, it's a pure anti-IL-1 beta. And I'll take abdacabart first. Phase 2 study, it's a press release, but they have a full kind of PowerPoint presentation. So the high score 75 at week 16 was 42.9% versus a real placebo of 25%. Side effects so far look pretty good. There were some injection site reactions, but it was equal across even the placebo group. Now, as for the finale, for this part of the talk, it's lutikizumab, which is a dual IL-1 alpha and beta monoclonal antibody. This was only a single arm study, so the high score of 50 at week 16 was 66%. They did observe neutropenia, elevated liver function tests, and a perianal abscess, which they listed as adverse events. So we have to see more with a placebo. But I think that's pretty exciting. We have some new targets that have never been tried before, new cell types that
Yeah, yeah.
nobody was thinking of, and there's more stuff coming, I'm sure. And I think if you have to have HS, it's good to have it now and not 10 years ago.
Yeah. And Alice, I mean, it's really, I mean, it's very encouraging. I agree with you. The B cell story, I wouldn't have thought that. So that's interesting to see. Let me ask you just to push that before we change topic. What do you think also the future is regarding, and I think you're a fan, so I think I'm speaking to a friendly audience. What do you think of combination therapy in the future? Because I have to say, we hit these ceilings, these therapeutic ceilings. You and I know from psoriatic arthritis, we've been looking at combination approaches because we hit a ceiling and we're sort of hopeful there. What about combinations here? Does this open the path for combo therapy?
Yes, some of us are trying it already, but you can imagine it's very difficult, especially in a population enriched for Medicaid patients, to ask for two biologics, for instance, to be used, or for that matter, even a JAK inhibitor plus a biologic, because JAK inhibitors cost about the same as biologics. So it's a very expensive form, and you get used to a lot of rejection, let's be honest. I mean, even with the commercially insured, but yes, I think there is a future for it. I believe that there's an ongoing literature review of actually led by Dr. Merola about combination treatments used in HS. And yes, people are trying to mix TNF blockers with IL-17 blockers, TNF blockers with JAK inhibitors. And of course, we've always tried to use other combination treatments like with rifampin, some of the older drugs. But I think what you're really referring to are two new drugs put
That's
together.
right. That's right.
And those studies need to be done and supported because if we just wait for large case series in real world practice, I think the insurance companies are going to have a problem with it. So if companies really want that done, they have to do it.
And you covered a lot of the sort of what's coming in the immediate current therapies arena. What's your experience been like with the IL-17 advancement? Because I know for many years we've had TNF inhibitors, of course, and many of us leaned into infliximab in particular. But what's the early experience been like with IL-17 inhibitors? Because I'm sure a lot of folks are either using them or thinking about using them in their patient population presently.
We have two IL-17 inhibitors that are actually approved for HS, secukinumab, which blocks IL-17A, and bimekizumab, which blocks both A and F. Obviously, there has not been a comparator study between the two, so I'm not going to, publicly state because it's only my opinion. Anyway, but both of them are exciting. They not Secukinumab came first. Bimekizumab has done more different kinds of studies because like they've looked at or even originally at draining tunnels and other things and just the high score and some of the standard regulatory scores. Um, Also, with bimekizumab, I know for a fact because I'm part of that study, it does matter to get a high score 75 versus a high score 90 versus only a high score 50 because the patient-reported outcomes are better. And we should remember that as part of the work that the International Dermatology Outcome Measures Group did, the number one domain that patients and everyone else voted for was pain. This is similar to atopic dermatitis in that if you have a drug with atopic dermatitis that doesn't control itch, you don't have a drug. If you have a drug in HS that doesn't control pain, you don't have a drug either. And I think it's very important to count the patient in. It's the number one domain.
So Alice, there's a long laundry list there. Any thoughts about topicals? I know there's at least one study looking at topicals for mild disease. Is that in our future?
It's actually in our present because, and we're doing it actually at UT Southwestern. It's with ruxolitinib topically for HS, but for mild HS, and the hope is that it'll be good enough to at least in mild HS give significant relief.
Excellent. Thank you. So with that, you sort of opened with some of the unmet needs. We're talking about therapeutic, bridges to some of those unmet needs, but I don't think anyone could talk about HS similarly these days to the psoriasis story without mentioning comorbidities. Comorbidities are, a crucial part of the burden of disease on patients. Do you want to recap for us what some of the common comorbidities are, and I maybe in the same breath, which ones you either directly address or you think about, co-management of in the current era?
I believe that HS has worse comorbidities than psoriasis. And to give you an example, even the CRP levels, they're much higher. They're even higher than psoriatic arthritis. I mean, they're approaching 20. The CRPs are like 17, 14 in a clinical study. This is a very high inflammatory burden disease. So obviously, you think about cardiovascular comorbidities, that includes all of the atherosclerotic disasters, whether it's a myocardial infarction, stroke, and also metabolic syndrome and all the components of metabolic syndrome. Obesity is clearly a problem, but I do want to point something out. Everybody assumes that an HS patient is heavy. It just isn't necessarily true. Some of my worst HS patients are skinny, and also some of I have no data to show for it, but I was thinking about it at grand rounds today at UT Southwestern. My ones with god-awful squamous cell carcinomas, they were mostly skinny men. And they get it. And so when doc
It's interesting, Alice, too. I've heard that from a few people that the skinny male patients can be some of the most
awful.
refractory and have a lot of the worst comorbidities. So it's an interesting observation.
And so and of course, smoking, I don't know whether you count that as a comorbidity, but when doctors refuse to treat patients with serious treatments and tell them you have to lose weight and stop smoking first, is, I think, cruel punishment. And I'm very much against that. We need to manage it, but it is not up to us to withhold treatment because people are not the ideal shape that they're supposed to be in. All right, so cardiovascular metabolic syndrome, obesity, diabetes, not a surprise, it's obviously a component of metabolic syndrome. For women, PCOS, polycystic ovary disease, and arthritis. And we know that Crohn's disease, I know that's not arthritis. Crohn's disease is associated with HS, but seronegative spondyloarthropathy is associated with both of those. And if you look for it, you will find it. And in fact, we have a instrument that can be used in HS and that we've used already, that the idiom MSKQ questionnaire that is picking up musculoskeletal complaints, including seronegative spondyloarthropathy, that nobody is asking in HS about. So I'll add arthritis to that. Of course, you can imagine with such a miserable disease that anxiety and depression is part of it. And of course, I just mentioned it before, malignancy. You need to really look in all those cracks and crevices in areas you might not want to look at all the time, but you must look at it because it can be harboring very serious squamous cell carcinomas.
Excellent. So I think it's safe to say the comorbidity burden is extremely high in this population. I don't know if we'll have time to cover all of these, but I have two questions in follow-up to you. So that's a long list. And before we turn people off to the treatment of the comorbidities, maybe a high-level view of which ones you feel the derm can own, screen for, which ones we co-manage. And the second piece, because I would be remiss if I didn't bring it up in 2026, you mentioned diabetes, obesity, you know where I'm going. Talk about impact of maybe GLP-1 and its counterparts, GLP-1, GIP, and other drugs in the current era in your thoughts for HS.
So I believe that what we can do that will have a big impact, even if we don't manage it directly ourselves, is to make sure that patients have a primary care doctor, that they see their primary care doctor and maybe even get a copy of the labs at minimum. At least do that, okay? That does not increase the workload terribly. Now, obviously, both you and I are internists and rheumatologists. We are not the average dermatologist, so we're comfortable giving statins. I'm comfortable giving the monoclonal antibodies that lower LDL. But at the same point, the most important thing is make sure that these patients get good primary care. That includes management of metabolic syndrome, decreasing cardiovascular risks, um, uh, and so that's that. And then getting to the weight loss drugs, I get almost um, angry about the situation. Of course, they should have these weight loss drugs. It should be available freely, but it's not affordable, and they're just too expensive. And for these patients, where a very high percentage of them are on Medicaid and some on Medicare, they're not going to get it. They're simply not going to get it. They're not going to, and when I was at Mount Sinai, I pushed the system to let dermatologists write for these drugs, but you just bang your head against the wall because unless somebody has frank diabetes, many patients are just not getting it. And no matter what kind of discounts available now, they can't afford it. So
Right.
I feel very strongly that this we must do it. On the same point, it's like being a diabetic in a candy shop. You just know that you can't partake of it because it's just
Yeah.
at this
Yeah.
point, and it's not cheap enough. And I think there needs to be political advocacy to make this available and more affordable for the people who need it the most,
Yeah,
actually.
that's great. It is a good reminder for folks that there are on-label indications for diabetes, for sleep apnea. In some cases, it's covered, in not all cases, and much less commonly, even with commercial, for obesity. But of course, then there's other access issues. So, but look, clearly going to change the face of many of the diseases that we treat over time. We've seen great data from psoriasis, psoriatic arthritis. I think we're still waiting in the HS arena. So, it's sure to reach our armamentarium, as it were, one way or the other. So I think, Alice, the next thing we have, you talked a little bit at the beginning about this, so maybe we can touch on it briefly. But the idea of treating early, you talked about it as one of your unmet needs at the very beginning. We've seen now from studies again, because we know the psoriatic literature so well, GUIDE study and others which have shown in psoriasis, treating early makes a big difference, in terms of, response to treatment, depth of treatment, ability to take a break from treatment potentially, and maybe even disease modification in some arenas. What about HS? What's the status there? When is it too late? What's early enough to treat?
Well, so it's very important to treat early. As I said, there are published papers that when they look at factors which um, help treatment or the opposite, inhibit treatment effects, the one that comes out is if people have a disease duration of 10 years or more, that's associated with a poorer response to treatment. It's also true that once you start seeing tunnels, that tunnels themselves are harder to treat than other areas of HS. So for both of those reasons, one should start treatment early. One should treat early stages 1 and 2. If obviously, as I said, I might be dead by the time a clinical trial would show that that has an effect on scarring. So what we really as dermatologists should learn how to use ultrasound to detect early tunnels, to at least detect inflammation. And there are other reasons why one wants to use ultrasound, but I really think that if you're really interested in HS and the companies who are interested in HS should fund education programs. We have handheld units that could be like dermatoscopes only for inflammatory skin diseases. And so I think that could help to make a study like that possible. I also think we need to intervene with surgery early. We first of all, try to find a surgeon who wants to do it. Okay, is one. It's not so easy to find, whether it be a dermatologist or a plastic surgeon. And when you do find one, you don't want to just reserve that surgeon to repair the disasters at the end stages of HS where they can't move their arms up and down because they've got contractures, where they can't urinate properly because the HS has affected the urethra. I mean, all these kinds of horrible situations. I think in the beginning, when you have limited disease, like in one axilla, let the surgeon do their thing. I mean, so maybe if not everybody with limited disease goes on to extensive disease, you might actually nip the disease in the bud. There's even and even hair removal lasers, something as simple as that may be helpful, which by the way is not covered by insurance. So
Yep.
that's an inequity issue there. But I think all of these things, intervene with surgery earlier, use ultrasound to be able to detect early stuff. Don't wait, 10 years sounds like a lot, but if they start getting it as teenagers, by the time in their 20s, they've had it for 10 years.
Yep. And Alice, I'm going to ask you to maybe just pause and come back to the procedures because at least one of the models that has worked well here at UT Southwestern, and Alice sees these patients at Dr. O'Brien
Jacko,
here. Jack O'Brien is has a whole program, and we have our PA colleagues who are really one of which in particular is focused on seeing these patients both procedurally, medically, for trials. Not every place has these programs, but and the ability to set this up. But can you comment on two layers here? Because one thing that we've seen work is to have the dermatologist potentially own some of the smaller procedures, and then a little bit buffer the plastic surgeon and help foster that relationship to say, we're going to send you the stuff where we really need you. We're going to own the stuff that's a bit smaller or more manageable by the dermatologist, whether it's on roofing, whether it's some of these other smaller procedures that are billable, that are reimbursable to some degree. And maybe just to comment on that. And, we've been fortunate to have a great handful of plastic surgeons at each of our respective institutions that own these. Any tips for folks in finding their go-to plastic surgeon that might own these, that might do some of the wound vac and other, pieces of this?
Let me get to the easier one first. It gets under education. I think dermatologists don't get much education in surgical procedures for HS. I didn't. I mean, and I think if you're lucky enough to be a resident at UT Southwestern, for many reasons, one of them is access to Dr. O'Brien. They'll learn how to do this. So yes, if dermatologists who like doing, and many dermatologists like doing procedures, would be educated in it so they could do it efficiently. Um, I think that's part of one of the education initiatives I'm thinking about. So that should be there. I think some pressure should be put on the American Board of Dermatology to include that so that if it's on the test, people will study for it anyway. So I think that's one maneuver. I think it's even when I was with them, I was at Sinai in New York City and I give you an example, for Medicaid patients, I could find only two surgeons willing to do it. And the reason why, whether they are Mohs surgeons, whether they are plastic surgeons, they don't like doing it because it's a lot of work at that stage, and it does not get compensated by the insurers particularly well, those bigger procedures. So I think the problem is that there's a paucity of people wanting to do these procedures. I don't quite know how you make that. I mean, that would be something maybe that at the level of the AAD RUC committee could bring that up and actually change measure what it really takes to do these procedures, and then work on getting Medicare and other insurances to compensate it for what it's really worth, because it is a lot of work, some of these procedures. I think so. Part of the reason is education, part of it has to be, I think, political in the sense of getting it better reimbursed so people will do it. I think that foundations should make available on a website a list of plastic surgeons and dermatologists who do surgical procedures so that patients can find them.
And maybe I'll just put in a plug here too, and a shout out. We have one of our amazing plastic surgeons from my old haunts, Dr. Dennis Orgel, who's at Brigham and Women's Hospital. I mean, he's a leader in this. I mean, he sees these patients, sees some of the most complex, does a beautiful job, and he comes and speaks and tells us about the plastic surgery view at our annual Masterclasses in dermatology meeting every year. And he's really a model for this. There are many other around the country. I don't want to sell anyone short, but what a wonderful educator, and what a great service. So just wanted to.
Makes miracles. And
Really? Yeah.
come
Yeah.
to Masterclasses, the annual meeting. It's every time. It's he just you see a miracle worker, and he's very modest about his abilities. And I wish we had more of these.
So Alice, I think we'll talk maybe since we're on education, just to kind of close that loop. We talked a little bit about educating plastic surgeons, educating dermatologists and procedures, and around some of the newer therapeutics, combo therapy, et cetera. But a lot of these patients, you also started with the unmet need gap. That a lot of these patients are not showing up to us first, unfortunately, right? There's this long delay in diagnosis. I don't know if I've seen a great quote that I believe in the delay of diagnosis. I think it's far longer than any of us, than even is quoted in the literature, especially for some of those, earlier and milder cases. But tell us about, how do we get to educate, and who else needs education around this? Where else are these patients likely showing up, and how do we educate?
I think primary care is certainly an area, emergency room, because these people come in and they all get their quote, they get their boils lanced, and that's all that's looked for. And then they might go home with some antibiotics, might not be the right one, but they go home with antibiotics. The other place is OBGYN, because the women will often, it's their private area, they'll go to their OBGYN before their primary care. So if I had to focus on, and if you want early diagnosis, it's not really the dermatologist. You really have to get to primary care, ER, urgent care ER, and OBGYN. Those would be the areas. And I remember when adalimumab first came out, because it was the first biologic. I remember telling the company that made it, I said, you have an average of 7 years or more of diagnosis till the label is put on. You need to educate the people who see them. And I think there's still room for improvement there. I'll leave it at that.
So we're getting a little bit closer to the end. We have a couple of other topics, but I have one topic that I think comes up not terribly infrequently, and I maybe just ask if you have any clinical wisdom and clinical pearls, which is there's a lot of overlapping features with IBD, with Crohn's in particular, and sometimes we see these patients with anal, perirectal lesions, or vulvovaginal lesions. And the question is always, wait, is this cutaneous Crohn's or is this HS? Any tips or tricks for folks who are sort of struggling with that in terms of diagnostic differences or pearls and making you think one way or the other?
I'm not sure I have pearls except the obvious. And the obvious is here you have to biopsy. Don't you have to biopsy to try to uh, and it may have to biopsy more than once if you're concerned that they have musculoskeletal complaints, as you've reported before in nice case reports. Get yourself an MRI of the sacroiliac joints if it's arthritic. You have to work with the gastroenterologist. I mean, there's no way you can do it by yourself. I've had, lesions, kind of up in the shoulder and, weird places. I mean, and so I think it's, work with the gastroenterologist. You may have to do GI imaging. If you're worried about a tract that's going to the surface, you're going to have to get some GI imaging, and that's right. And
Yes,
and
yes,
biopsies, and if
yes.
they have low back pain, you have to ask about it. They're not going to volunteer. Everything hurts down there, so they're going to not volunteer. That you have to kind of get it out of them and get then the rheumatologic imaging. But that is not managed by derm alone.
That's great. No, and we again not an intentional plug, but you just jogged for me. We always have a gastroenterologist, IBD expert as well, come to master classes. Typically, Dr. Ryan Stidham, who's an IBD guru, and he has shared with us some of the imaging protocols. Right, looking for a fistulogram, an MR, MR fistulogram, with contrast and such to try to distinguish Crohn's from HS and such. And sometimes sometimes it's both, right? And there's overlap as well. But that's excellent insights. And I guess what we'll probably wrap up with is the last topic is a little bit about advocacy. I know, Alice, you're very passionate about this. Alice has been a staunch advocate for patients with many of these diseases for decades, for psoriasis, for psoriatic arthritis, and for HS. And we have a number of organizations in this space. I know NPF in particular is a flagship banner organization for patient advocacy in the psoriasis arena. Similar organizations in HS. Do you want to comment a little bit, maybe, Alice, about where you see some of the unmet need and where folks can advocate on multiple levels for their patients with HS?
Well, first of all, I mentioned IDIOM already the first time, and in IDIOM is the International Dermatology Outcome Measures Group. We have three of our board members are HS patients, and we develop outcome measures that are useful in clinical practice, not just research. And you need to have good outcome measures because if you can't quantitate it, you can't really say whether it's got significantly better. And so patients have a large impact there. The FDA comes to it, including healthcare providers, scientists from industry, and nonprofits. So there's an area where the patient voice is heard, and I think that's important. And the patients are very grateful for that. And they've even said it's the only place where a patient voice is heard. There are other places that there's a HS Foundation, and I'm sure there are internationally other groups. I do think it would be important, and I'm hoping I'm an incoming vice president elect. If anybody, if I can volunteer it, I would like to volunteer that somehow. Maybe we can talk about bringing this up with the RUC committee to try to get reimbursement for surgical for procedures for HS to increase because they are time consuming, especially when it's god awful HS. It can be hours, and they get very little for that. And so if doctors got better reimbursed for it, maybe more doctors would do it.
That's excellent.
Oh, it's
Thank
political
you.
and
Thank you.
economic.
No, it's wonderful. I mean, look, we're trying to, hit the disease on all fronts, and it's really important. We would be doing a disservice if we didn't talk about the advocacy piece as well. So maybe, we've covered a lot. I mean, I'll just summarize, and then I'll, ask you if you have any closing remarks on the disease state as we look forward. But, what I heard was a lot of hopeful commentary, right? So we talked a little bit about where the unmet needs are to start with, and that, many of those are addressable, some more than others. But at least from a depth of response standpoint, it's incredibly encouraging that we have drugs right now that are changing the face of HS, that we have a whole pipeline of emerging therapeutics with very promising data that you shared with us that are coming, which is, again, incredibly encouraging. And then we talked a little bit outside the box about things like combination therapy and such, which is tremendous. You covered the importance of medical and surgical and procedural interventions. You talked about early, see, I've been listening. You've had your impact. You talked about early intervention mattering, and then multidisciplinary care with regard to comorbidities, among other things. So we covered a whole lot in a relatively short amount of time. So, and then even advocacy and where we need to go there. So maybe for the last word, anything else we either didn't cover or you want to reemphasize, moving 2026 even into 2027 for the care of our HS patients, and then we'll wrap up this SML morning topic on HS.
I think this is not novel, but I think it's always effective. Take the time to listen to your patients. They need to be listened to. They have a chronic illness that really impacts their life. So take the time to listen to them. Please don't make them feel dirty. Don't make them feel that they have bad personal habits, and that's why they're in the position they're in. It sounds very elementary, but I can't tell you how many patients have been treated that way. I mean, sometimes they think that they've been told they have a venereal disease because the doctor thinks it's a venereal disease. And so I think it's important. Give your patients hope and respect and listen to them. It's worth the time.
That's perfect wrap up. So with that, thank you, Alice. It's always a pleasure having you on Saturday Morning Live. This time as a guest, even better. And for everyone listening, stay right where you are. We have a fantastic lineup ahead this morning with conversations and insights that you will not want to miss. Dr. Gottlieb and I are back together at 10 a.m. Eastern for our live Q&A session. So be sure to stick around for that as well, and we'll see you soon.
Thank you.